Afternoon, everybody, and thanks to the HRB for the opportunity to present. Just to acknowledge this is the research we're doing is from a collaborative research team with our colleagues from University College Cork, University of Southampton and University of Technology in Sydney. And as Anne said, we work very closely with the HRB and the Department of Health in particular on this program of research. So we work with a number of knowledge users within it. What do? It sounds quite simple, but it can be very complex. We have been tasked with to identify models of nurse staffing that are based on patient or resident need. We implement those and then we test the outcomes. But with working with these knowledge users, both in the public sector and recently working within the private sector, in the private nursing home sector, we've identified that there are a number of social, political, and contextual issues in working with knowledge users and how we transfer the research that we're doing into practice. And these knowledge users come with a variety of different perspectives and different needs. Variability within hospitals, we find, is much greater than variability between hospitals. So you can have two medical wards side by side in the same hospital, and it's like stepping out from one world into another world. They can be extremely difficult due to leadership, due to funding, due to staffing levels, and so on. So what I'm going to talk about is how, from my experience of working with NICE in the UK when I was at the University of Southampton, and with the Department of Health, how this transfer of knowledge works, some of the good and some of the bad, and some of the surprises we've had along the way. So a lot of the research we do is responsive to policy need. So the first time we really worked with policymakers was when I was at the University of Southampton, and Francis had brought out the report of the Mid-Staff's NHS Foundation Trust Inquiry. And this report found that there had been excess deaths due to poor care within the Mid-Staff's NHS Trust. And Francis recommended that NICE would undertake a program of work to look at new models of safe nurse staffing within this particular area. Now, what we commissioned, we applied for the research with NICE, and we were lucky enough to be funded for it. And what we did is we undertook an evidence review, and we communicated that evidence to NICE in relation to it, and then NICE developed the safe staffing framework for nursing in adult inpatient wards. So this is now implemented in all hospitals within England. It was particularly looking at England, and that was a relatively straightforward process. It opened my eyes to the fact that you needed good evidence. You really needed good evidence to work with them. You needed to be able to communicate that evidence to a wide audience within the National Institute of Health and Care Excellence. They had a number of key stakeholders that you worked with. The provision of evidence was very formal. It was over 2 days. You were in a big boardroom. It was a bit like the UN. Everybody turned on and off their mics as they spoke. But it was a very formal process. And they picked apart each stage of the evidence that we had presented in relation to was it usable. And then these guidelines were put into place. Within Ireland as well, what we have found that working with knowledge users is there's a need to be responsive to crises that occur. And we know the health service in Ireland has a number of issues and challenge and crises, not least industrial disputes, industrial action. So a lot of our research has come as a consequence of nurses withdrawing their labour within clinical settings because of various issues and so on. And what we find is that when there is a political crisis, or when there is a crisis within the health services, that the knowledge users or the Department of Health, when they know that there's a team there that has a record of a program of research, of outputs, of knowledge of an area, it's you they'll come to. But that takes time. Building those relationships with our knowledge users takes a lot of time, takes a lot of energy. And as I'll show you in a moment, sometimes we think, as academics, sometimes we can think linearly. We do the research, we publish, and then we hope everything will change. And I'll show something in a moment how that doesn't work. The other thing we found when working with the Department of Health with our research team is need to be flexible. So our path has been set out. We were to look at medical surgical settings, and then we were to move into emergency settings, and then the community. But COVID-19 came along, And during the pandemic, we saw an increase in death rate within the nursing homes. And that staff came under increasing pressure within that. So the COVID-19 Nursing Homes Expert Panel made a number of recommendations, and one or two of those recommendations around staffing. So our research team was able to flex into that. And we're now within the nursing home sector testing a model to determine safe staffing levels within the nursing home sector, and also what's needed to respond if there is an outbreak of COVID-19. So my cornflakes, how did this come in? This is where things went wrong working with key stakeholders. Cornflakes has nearly choked on my cornflakes one morning, sitting in my flat in Winchester, getting ready to go to work in Southampton. And those of you who listen to BBC Radio 4 know that between 6 a.m. and 9 a.m. is the Today programme. And on the programme, the next item came up was that NICE were withdrawing the safe staffing guidelines for emergency settings, which we had worked on. So the cornflakes were choked and spat out, and it was a big scramble to the newspapers, and this is what we saw. Now, you know, in Ireland we have less than 6 degrees of separation. In the UK it's about 20 degrees of separation. But NICE to publish a report on NH staffing despite being told to stop work. NHS held back report into unsafe hospitals minutes after email exchange with Jeremy Hunt. Exclusive NICE safe staffing U-turn followed meeting with Hunt's office. So this is where things went wrong. So we had, after our success of presenting the evidence on safe staffing in medical surgical, we were then commissioned to do emergency settings. But what happens is when you look at the evidence on safe staffing in medical surgical, there's abundant evidence saying that safe staffing levels lead to reduced mortality, reduced adverse events, and better staff outcomes, reduced burnout, higher job satisfaction, and so on. Then the evidence falls off a cliff. When you look at emergency settings, when you look at community settings, when you look at older person settings, it's not really there. And we had said that to NICE. We had said that there is evidence that safe staffing in emergency departments is related to time to triage, it's related to patients leaving without being seen and so on, but it's weak, mostly from the US, mostly in single sites, and there'd be questionable about the controls that were used. But NICE went ahead and published, and then it got political. So the other lesson we learned that research, when you're working with policymakers, can be political. And when it reaches the Secretary of State for Health and they disagreed with it, they pulled it. So the safe staffing guidelines for emergency settings in the UK were pulled. They were published, they're out there on the web. NICE did publish them, but they were never implemented. The other thing we've learned is that working with knowledge users, both at clinical level and within the Department of Health, takes a lot of work. So this, Evans in the World Bank talks about you eventually get your article to the policymaker, he reads your study, he or she changes everything, and then they end poverty. It doesn't work like that, unfortunately. There isn't that linear. It's messy, it's complex. There is very much a process of working very closely with the knowledge users, and it's very, very complex process. And it takes time to build those relationships with them. And that's where the change comes about. Vitamin C, not something I research, but vitamin C. Well, we know that the British Navy's adoption of oranges to reduce scurvy, vitamin C, from the study by Lind in the 1770s took 40 years for the British Navy to put it into place. And we know that on average that research getting into clinical practice still takes on average about 17 years. So one of the things we find is there's research time and there's policy time. And when you look at policy users or knowledge users, they're within a cycle, they're within a funding cycle, they're within a decision cycle. Research sometimes isn't within that cycle, and we can work parallel to each other without coming together. And this has led to issues in relation to trying to get research findings into practice, because policyholders have a very different, policy funders or policy makers have a very different cycle than the research cycle. And when you're working with knowledge users, it's trying to match those two cycles together, and it can be very, very difficult. So what have we learned working with policy users? So we give them timely access to good quality research. We undertake systematic reviews, scoping reviews. We look at that very closely. We collaborate very closely with the knowledge users and policymakers. Everything from working with staff on the ground in the nursing homes right through to high-level meetings with the Department of Health. Research evidence is just one piece of evidence that policy users use. They use a lot of other evidence. They use consultation. So it's not only research. We found it's not just the research evidence. They will use a lot of other evidence in relation to that. What we found as well is being very flexible when working with knowledge users, and sometimes they look for information that we may not have, but then we'll sometimes try and find. And then co-generating research questions is another area. We found reaching out, calling people, emailing people, arranging meetings with people. In Ireland, we don't have 6 degrees separation. I'd say everybody in this room knows somebody who knows somebody. We have 2 or 3 degrees of separation, and we can reach out very quickly. And we found that's been very effective in translating our research into policy levels. The other thing is that we found very useful is making use of our arguments. So we know that we've got an aging population, it's aging well, but as we get older, we're going to require more healthcare. Within that, though, we need a greater nursing and health and social care workforce. So we go to the policymakers with 2 or 3 key messages. And one key message we say at the moment, there are approximately 4 workers for every 1 person over 65 years of age. In the next 40 years, there's going to be 2 workers for every person over 65 years of age. Now, that's not healthcare workers, that's all people of working age within that. And that message gets people to listen. How are we going to recruit staff? How are we going to retain them? What type of models do we need? So we find going with 2 or 3 key messages in relation to what's happening, and we make use of CSO data, we make use of ESRI data within the arguments we're making. So to conclude, what we have found is really important is looking at things like hinge actors, those people who, what Kyoda, who works in the World Bank, talks about. They're those that can communicate and operate across a number of spheres. They can operate academically, they can work with policymakers, and they can work with practitioners and patients and their relatives. Another one is knowledge brokers, is bringing that knowledge forward and developing that, and putting knowledge utilization and knowledge transfer into PhD training programs is a really important element in relation to that. Communicate effectively. We're currently working with the nursing homes, and it's been, I thought emergency departments were complex until I started research in the nursing home sector, and they are probably one of the most complex environments I have ever worked in. So we need to be able to communicate in them. So we use multiple communication activities. We've developed an instrument or a tool that helps them determine the number of staff that they need based on resident dependency levels. It sounds simple, but there's complexity within the tool. So things like videos, things like training videos, things like websites, resources, face-to-face. We use multiple tools of communication, and we co-produce it with them. We build on their capacity to use the research, feeding back the research results in a way that helps them to implement them and facilitate them. Working with the fund holders in relation to identifying research priorities is really important, and looking what there is, and looking at the perspectives from multiple stakeholders. We found that's been really important. Flexibility, as I mentioned, and then having a paradigm shift, which is really looking at how do we change the way we do this work? How do we work with various elements within it? How do we communicate effectively? And then a lot of the knowledge users don't have the supports that we have within the academic setting. They don't have access to research journals. They don't have access to evidence. They're behind firewalls. They have to pay for them. So we're able to do that. We're able to work with them and providing that level of evidence, which is really important. We think they have that, but a lot of times they don't. So instead of taking 17 years to get our research into policy, because of the model we use, these are the policy documents that our research team have worked with the Department of Health in developing over the last 5 to 6 years. So the first one was a framework for safe nurse staffing in medical surgical departments, which is now national policy. That's been implemented nationally, a new model, a new way of working. The emergency department one has now been rolled out. That was produced last year. We've informed advanced nurse practice and the new framework, the new expert review on nursing and midwifery. They drew heavily on the work that was funded by the HRB and the Department of Health. And it was through that partnership and communication approach that we did this. Just finally, to finish, to acknowledge the funding from the HRB and the Department of Health. Without this, none of this would have happened. Thank you.